It is my honor and privilege to introduce the moderator, who will then introduce the panelists. Dr. Beverly Greene is a board-certified clinical psychologist and professor of psychology at St. John's University. She is a fellow of the American Psychological Association and the Academy of Clinical Psychology. Very impressively, she has over 100 publications, and even more impressive, 12 of which received national awards. She has also received over 40 national awards and 2 APA presidential citations for her work. Along with all of this, Dr. Greene has the distinction of being one of the Black pioneers in mental health. And without further ado, I would like to introduce to you Dr. Beverly Greene.
Thank you, Marlene, and thank you for the opportunity to be here. The work that we're going to be discussing tonight is part of a book project that we are developing for Division 44, the Division of Sexual Orientation and Gender Diversity of the American Psychological Association's book series. My esteemed colleagues, Dr. Marie Meville is the Vice Dean for Faculty Affairs at Teachers College, Columbia University. And in that role, she coordinates many aspects of faculty work life, including organizing the new faculty orientation, assembling mentoring committees for pre-tenure faculty, preparing summary reports for the provost's office regarding tenure and promotion processes of individual faculty members, meeting individually with faculty regarding any concerns they may have, and providing support services for faculty during the retirement process. She's responsible for creating faculty development workshops and events and nominating faculty members for external awards. She is also a professor of psychology and education in the Department of Counseling and Clinical Psychology. She's the author of 3 books, including a newly published book exploring the experiences of women in STEM fields, and over 65 publications dealing with multicultural issues in psychology. She is the past associate editor of the Journal of Multicultural Counseling and Development and was the book series editor for the American Psychological Association, Division 44. She previously served as president of the Latinx Psychological Association, president of the Council of Counseling Psychology Training Programs, and the vice president for education and training for the APA Division 17, the Division of Counseling Psychology. Dr. Meville is an APA fellow, and prior to her current administrative appointments at Teachers College, she served as college ombudsman, director of training and program director of counseling psychology, and chair of the Department of Counseling and Clinical Psychology. Dr. Angela Ferguson is an associate professor in the counseling psych doctoral program at Howard University in the School of Education. Prior to arriving at Howard, Dr. Ferguson taught at George Washington University in the Organizational Sciences Department, where she taught decision-making to Air Force captains and Navy lieutenants. During her tenure at Howard, Dr. Ferguson has served as director of training for the Counseling Psychology doctoral program, as well as director of graduate studies for the School of Education. She has also served on several journal editorial boards, executive boards, and committees in the American Psychological Association, the editorial board for the Counseling Psychologist, and for the Journal of Multicultural Counseling and Development. She has also served on the executive committee of the Council of Counseling Psychology Training Programs and executive committee of Division 44, the Society for the Psychological Study of Lesbian, Gay, Bisexual, and Transgender Issues, as well as the Committee on Lesbian, Gay, Bisexual, and Transgender Concerns Committee of APA, and the executive committee of the Society for the Psychological Study of Culture, Ethnicity, and Race, and is currently sitting on the Leona Tyler Committee of Division 17. Dr. Ferguson Her research areas focus on the intersections of race, gender, and sexual orientation, and trauma and resilience factors within international culturally diverse populations. She has edited a book titled The Handbook of Race, Ethnicity, and Gender in Psychology, published in 2014, which includes 2 chapters she has co-authored: Intersections of Race, Ethnicity, and Gender on Identity Development and Social Roles, and Intersections of Race, Ethnicity, Gender, and Sexual Minority Communities. She has also published several journal articles and book chapters focused on intersections of race, gender, and sexual orientation, as well as delivered numerous presentations and workshops at local, state, and national and international professional conferences, such as the American Psychological Association, the International Society for Traumatic Stress Studies, the Antares Foundation, and the University of Oxford in England. So, welcome, my friends.
Yes, welcome everyone.
Yes.
Our presentation today is meant to be more of a discussion organized around the concept of the rainbow that never was, and examining liberation psychotherapy for lesbian, gay, bisexual, transgender, and questioning people of color. Both mental health and as well as medical practitioners who treat sexual minority persons of color face challenges in making their practices friendly and competent, and that training often still fails to address. Both lesbians and gay men and those of color are members of distinct cultural groups. Those groups both sit at the margins, at the intersections of identities, as well as at the margins, because they are both marginalized groups. There has been some movement in the mental health and medical profession toward viewing non-traditional sexual orientation as a normal variation in psychosexual development. However, that has not always been the case. One of the common features of both of these groups is that they each have a history of having been marginalized by the dominant cultural narrative, and in 3 distinct institutions in our society, that marginalization and subordination has been enforced. One is law. Both gay people and certainly in the history of African Americans, the free Black Americans were criminalized. Interracial marriage was criminalized. In medicine, where people who are in each of these, there is a way that society exercises a kind of discriminatory control over people, essentially, that they don't like. Medicine pathologizes them. They're sick. And so family structures of people of color, in the degree to which they differ from those of the dominant culture, have been deemed pathological and have been used to attribute fault for the kinds of problems that we see in those families that are most often a function of trying to manage the vicissitudes of racism. In another institution, again, used to ways of society legally controlling people that they would otherwise not be able to do, is religion, in which people are considered either sinners or to have no soul. And each of these categories, in many ways, afford society the opportunity to deny opportunities and interfere with the freedoms of people for whom they would otherwise not be able to do that without perhaps looking like the oppressors that it makes them for doing so. Despite the growth and prominence of research in many areas, bias in practice continues to persist. Many training programs still do not routinely address the special considerations in the treatment of such patients, nor do they address the effects of the history of biased research on practitioner attitudes towards sexual minority clients, as well as racial minority clients. People of color have endured a history of discrimination and bias that doesn't exclude medical and mental health professionals. Many of this large and diverse group don't trust doctors, in part for that reason. Western medicine or the medical establishment, for some, their distrust is based on a history of negative or harmful experiences directly experienced or told to them, encountered when seeking professional medical or mental health assistance. Others base their distrust on disgraceful historical episodes in which members of minority groups were used in medical research in ways that were harmful to them. The obvious example being the Tuskegee experiments. Hence, people who are from both groups have the potential of being poorly understood, but also have the potential of being wary of mental health professionals and the medical establishment. Most of the research on gay men continues to be based on samples of primarily white gay males, as well as the predominance of literature on lesbians. Similarly, the research on men and women of color rarely makes distinctions between their heterosexual and gay and lesbian counterparts. One can sort of get the impression that if you're talking about Black people, for example, you're always talking about heterosexuals. Heterosexist and ethnic bias can lead practitioners to make a range of assumptions about members of this group that are erroneous. We want to look at the treatment of members of this group and raise the question, what are the challenges? And aside from what are the challenges, where do those challenges come from? Is the challenge in the nature of the population that's being treated, or is the challenge in the failures in many different ways on the part of the therapist? Angela, Marie, would you like to jump in?
I'll go ahead and jump in, and I apologize for my hoarseness. No, I guess when you were talking about is it the failure of the therapist, in some ways our training has failed our therapists in terms of being able to look at the complexity of intersectionality. I don't think many of our programs truly look at those kinds of intersectional lenses, look at our clients through intersectional lenses, such that the therapist is then capable, or at least competent, feels competent, both theoretically, to use theoretical perspectives to work with that individual and to conceptualize what's occurring for this individual. So I think it's really much of our own failings as a field in terms of not providing our trainees with substantive information and clinical cases that allows either the new therapist or even the existing therapist to be able to competently look at this individual and work with this individual such that not just so much that they're friendly, but that they're capable of being able to walk them through and assist them and guide them in the issues that they're bringing forth in the session.
Mhm.
And I can start out by just quickly restating the points that Bev started out. I guess we'll be on first name terms here, that Bev began with, and I'll just say it very quickly. That queer folk, especially queer folk of color, have long been considered sick, criminal, and sinful. So by the fields of medicine, law, and religion, we have been negatively seen, talked about, discussed, and it's no accident. It's not an accident that these terms and this failure that Angela just referred to of training has occurred. And so the use of our term liberatory psychotherapy in our title is very consciously done. And that is to look at the ways that our clients, ourselves, have been oppressed, have been marginalized, have been silenced, even in terms of even coming to an awareness of ourselves in positive and healthy ways. It's not an accident, because we're talking about dominative structures that privilege some at the risk and even at the violence of others. And I know many of us are thinking about the decisions made last week by our very own Supreme Court as yet again returning us to some deeply divisive, oppressive, and I would even say violent ends because of these decisions. So this is not something that's happened by accident, but actually has been hundreds of years in the making. And so tonight, we look forward to engaging in conversation with all of you, not just about our failures and our invisibility, but of how we can reclaim our historical memory, which is a foundational principle in liberation psychology, to the not just to know it, but then it's knowledge plus action. And so it's the engagement with these multiple, actually with our communities, with ourselves, with each other, that we can continue to fight to change these oppressive structures in our society. And we'll just today focus on the United States, because that's already a complex enough society to talk about.
One of the things that I think is paramount when looking at members of these groups is the way that multiple prejudices converge, and how complicated it is to negotiate those multiple prejudices when, in terms of looking at this notion of the rainbow, that kind of connotes a mythological sense of within group harmony, that also is problematic, in that within each group there is a history of a failure to accept members of the other group. The LGBTQ community has never been without its racism, and certainly communities of color have their own variations on a theme of homophobia and heterosexism. And there are differences of opinion about why that is, but often the question arises that, how could a group that experiences discrimination practice discrimination on both sides? And I think the reality is that having experienced social oppression doesn't necessarily make people tolerant just by virtue of that experience. It depends on what they have done with that experience. What did that experience mean to them? How does it position them in the social hierarchy? And how do they experience or understand that? Is that desirable? What is the desirable outcome? James Baldwin, who was fairly out as a gay Black man for his time, because many African-American scholars, writers, and personalities who we some of whom we know, some of whom we think may have been gay or lesbian, would not do that out of the reasonable assumption that it would collapse their careers. He was asked in an interview once, the interviewer said, well, you're Black, you're poor, you're homosexual. You must have thought, well, boy, how much worse could it be? And he smiled, that big beaming smile of his, and he said, well, no, I rather thought I hit the jackpot. And the interviewer expressed some concern and said, well, what do you mean? He said, well, because it's so outrageous, you can't go any further except to do something constructive with it. And when he was asked about why there wasn't more cohesiveness between Black and white sexual minority communities, he said, well, you must understand that by the time a Black person understands that they're homosexual, they've been so menaced by society about their race that it's sort of not new. It's kind of, oh, well, this is now another thing. But they understand something about being on the margins that doesn't make being marginalized this sort of new and unfathomable experience. Whereas among their white counterparts, they come to find out, in essence, that they're a member of a club they've been taught to despise, and that the previously privileged position that they held is no more. And so their disposition towards the dominant culture is more one of betrayal and disappointment, with perhaps a desire to regain that privilege, than one of understanding, okay, this is now another thing. What am I going to do with that? Would anyone just jump in?
I was just going to say, and I think an important point related to what Bev is talking about is we talk about minority majority, but these are not necessarily about numbers, right? It's really about, frankly, a minority in power that attempts to disempower, decentralize the voices and actions of many, many people. So when we talk about minority, it's not really about numbers necessarily. In this country, it can be, but it isn't if we think about gender groups. And there are multiple gender groups, we all say. But when we think of the non-cis male group, that's already a majority of people that we're talking about. So it's about who has access to say, what is mental health? What are the symptoms or signs of illness and dysfunction? And how do we understand and talk about symptoms without understanding the larger context in which people live? And so I think that's a really key thing when we start talking about intersectionalities, as Angela referred to earlier, that we have to understand people, ourselves included, within a context, a larger context, in which multiple forces can keep us from ourselves feeling whole, or even when we think about ourselves, that we think about ourselves in positive, affirming, and expansive and visionary ways.
One of the things that I was thinking about when Bev was talking about the positionalities of different folks is that it's important to understand, especially within the minority sexual gender population, and why that rainbow isn't the same for everyone, that the position of a white lesbian, for example, is different than the positionality of a Black lesbian. The opportunities afforded to, even though both are considered minority group members, access and privilege is still different for each of them. And so it's hard for members of the LGBTQ community at times to be able to meet each other in the middle, because their privilege and access is different. And that access and privilege has been long held, not just, as you were saying, Bev, when you were giving the example of James Baldwin, but that privilege has been long known for a white person before they may have more understanding and awareness of their sexual minority status.
Mhm.
And so that really, so for that individual, it's a very different story, very different unfolding and navigation of how I now deal with whatever discrimination or oppression may come my way. And I think it's also important that we keep in mind that oppression and discrimination is not necessarily additive. Yes, it is one more, it is another, it is seemingly, you can have 2, 3, and 4, but the way the individual experiences those types of oppression or forms of oppression doesn't feel additive, but it feels like another way in which they may either have to navigate marginalization and navigate how to reconceptualize sometimes who they are and their identity, not just for themselves, but with others.
Mhm. And how those things are occurring between each of these groups and the dominant culture, but also within each of these groups around hierarchies of privilege and disadvantage. And it complicates the nature of what members of both groups encounter if you look at it from a developmental perspective. The idea that coming out is a significant developmental event for members of sexual minority groups is relevant in that what that means if you are a person of color as opposed to their white counterparts may be very different. We know that people of color tend to rely on their communities of color and families to a greater extent than their white counterparts, that often those places are havens against racism. However, they may jeopardize them if they are in particularly homophobic surroundings and they wish to present themselves more authentically. And so what it means to do that in any given place has to take that into account. Similarly with employment, where negotiating racism and code switching and those sorts of things are a reality for people of color in employment settings. It now becomes more complicated if one is adding the desire to be authentic in terms of sexual orientation. And I think what Angela is, what I hear you stressing is that it's just densely complicated. And it's important to avoid sort of reductionistic explanations for, or prescriptions for people, as well as considering for the therapist, the importance of considering what a subjective experience is like outside of your own experience, sort of stepping outside of your own head and your own person and looking at the world through the eyes of the patient, which may be very different. Even if you're in the same situation, what that looks like, feels like, and the kinds of choices someone may have may differ. And that many of these things are connected to real social phenomena. They're not just idiosyncratic individual experiences of the individual that you're seeing. Often racism is responded to as if a person is making much ado about nothing. That we don't have that anymore because somehow having a Black president means we're in a post-racial world. Nothing could be further from the truth, as evidenced of what happened in the election when he left. This turbulent climate in which what seemed to be previously acquired rights and opportunities could easily be taken away, is one in which many people may find it disturbing and scary. As we're talking about the decisions made in the last week by the Supreme Court, there has been a sort of dog whistle call by Justice Thomas to revisit other court decisions, essentially inviting people to come and bring challenges to the Lawrence ruling around criminalizing sodomy, and the privacy considerations that were part of that ruling, the Brown v. Board of Education ruling, the Obergefell decision that led to the legalization of same-sex marriage. He didn't target Loving versus Virginia, which was a similar case, which would seem rather disingenuous. Not that I think it should be targeted, but it is in category no different than the other cases that he has invited challenges to. And so people who thought maybe they had the right to something that was secured and secure are realizing that that's not the case, that it revisits the idea of safety and what people can depend on, what they can't depend on.
Yeah, and I think this is where the notion of the rainbow that never was also is quite relevant, because as one right falls, I've heard language that uses, just words to bring other people who might fight for one right or for one group to come and join with the group that wants to take rights from yet another group. And so, I think there's some manipulation ongoing now that continue, the phrase divide and rule, that the rainbow that never was is also being involved in how even the discussion, the public discourse around these decisions is being done by the people in charge or in favor of these decisions. So we can expect more of this divisive, polarized ways of thinking, acting, and deciding, because it serves the purpose to divide communities that might otherwise want to join together for a larger social justice initiative.
And I think not only does it divide communities, I think it can be psychologically stressful for the sexual minority person of color. This individual belongs to multiple groups, and one's identity is involved in that splitting and that kind of attack such that if one part of their identity had not been or is not fully developed in a way that we might consider healthy or psychologically grounded for them to feel like a whole person, these kinds of decisions continue to split them too, and marginalize them too, and force them perhaps, or at least it may feel compelling, to continue to be invisible in one of your identities versus another identity.
And I'm sure, as I have, you have also had patients who have, during the propositions that were popping up around the country to put same-sex marriage to a vote. I know I saw people who talked about feeling a lack of safety in a way that they had not prior to that. A sense of, saying, well, I live in this neighborhood and my neighbors are very friendly, and I sort of like, this is my home. And suddenly I see these proposition signs popping up on lawns all over the place, and I feel like I'm in enemy territory. And so that sense of people feeling like not knowing where they stand or could stand, and it begs the comparison of how do people determine what's safe and what isn't? That, again, it can be turned on a dime. This notion of playing divide and conquer, which is an old one. and is often trotted out to dilute the concerted efforts of groups for whom there are important common interests, but are driven to see themselves as competitors. It is used, it has a long history of being used to undermine coalitions, both within marginalized groups as well as between marginalized groups. And they often find their greatest currency in sectors of the population that are most oppressed by them. That, you know, they often proliferate in periods where disparities and contradictions in wealth and power are greatest. These coalitions within groups and between them are often disrupted when materially successful group members are enlisted to chastise their vulnerable or less successful counterparts for their own misery, while holding themselves up as examples of either the eradication of or minimization of social inequity. And when we see marginalized and colonized people behaving in ways that are self-defeating, that's only half of the story, because their derivative behavior is many times used to conceal what is an intransigent nature of the structural assaults on them that are systemic in nature, but are often harder to see and harder to sort of figure out, well, then who do you blame? What do you do? How do you address that? Which can leave people feeling more hopeless.
You know, Freud, writing almost 100 years ago, made that same observation. You know, one of the more interesting readings I came across, and you know, in our conversation, my conversation with Bev and Angela before the workshop, was just how much the origins of psychoanalysis were embedded in a progressive state, and that Sigmund Freud, as a Jewish German person, was targeted, was part of a targeted anti-Semitic focus. Obviously, he was exiled ultimately from Germany because of the rise of Nazism. And he wrote in the 1920s, he has a very interesting book where he talked about exactly what Bev was saying, that those who are oppressed eventually are weaponized into becoming oppressors themselves. And so that social justice is really about developing a law whereby all are a part of the process. So, you know, psychology, we have a you know, a back and forth relationship when it comes to advocacy and social justice. But for me, I felt it, I don't know, a positive thing to learn that one of the founding people of our field began his career and was actually throughout much of his career focused on progress, focused on social justice, even those other writers acknowledge when it came to issues of gender, for example, and other and some issues of race, he wasn't, right? So there is that just complicated relationship with understanding what is oppression for oneself, but also understanding what is oppression for someone else, and how am I, a person, a part of the oppression of somebody else as well as myself. And so, you know, we actually, thankfully, we're not the first or alone, but it's just amazing because he also talks about the cyclical nature of oppression, and that if you look at human history, it's been a part of humanity, as well as the fight against it.
I think that, Marie, that's one of the hardest things I think therapists have to do, which is to sit with their client and understand, and perhaps maybe sometimes for the first time, ask themselves, how have I been a part of the oppression that my client is talking about and they're describing? Most therapists, I think, breathe a breath of fresh air and relief when they say, oh, I have not done anything. I've been an advocate. However, they may not realize how they have benefited from some of the structures of oppression and discrimination. And therein, I think, really lies the challenge for therapists. You personally may be in places and spaces of advocacy as you know yourself, as you see your behavior. But have you also asked yourself how I've benefited? Because that continues to perpetuate the structures of oppression. And that may be an incredibly positive conversation to have in the room with your client, not so much how you've benefited so much, but how do they see you?
Mhm.
How have they experienced group members that they at least think you might be a member of? And can they have that conversation to talk about the pain that has engendered and that they are negotiating? But if a therapist hasn't asked themselves those kinds of questions, I think it's very difficult to be curious about what kind of oppression, how have you been dealing with the oppression and discrimination that you're describing right now?
And that when you try to launch more complex analyses of these situations, they are trivialized as, well, that's just blaming the system. And as, politically liberal failures to encourage people to take personal responsibility. And when you position those things in that way, well, of course, it's important for people to take personal responsibility for their behavior and not to abdicate personal responsibility. But sometimes the things that we are looking at in patients whose identities are embedded in marginalized groups are not pathological. They're not a sum of symptoms, but they're trying to cope with social pathology. And depending on the kinds of resources that people have, some people can do that better than others, but that their behavior isn't taking place outside of some context, that they're managing broader social phenomena that are real phenomena. They're not things that they're just making up or, using the race card or, those sorts of things that are used to trivialize genuine concerns, but are deeply painful and deeply felt. And something that I think sometimes happens in therapies with people who are struggling with these issues is their need to express intense emotions around them. And therapists who've not done the work often will find that scary and sort of want to put a lid on the expression of those emotions. And that's simply the most unhealthy thing that you can do. When people are expressing what Cornel West calls the grief in their grievances, it's important to hear the pain that resides in the grief, and offer some kind of validation for their appropriate perceptions of reality in which they're being treated unfairly or they're being harmed. And it isn't simply a function of their not being active enough or not being smart enough or not wanting to work hard enough, or all of the things that get thrown at people who struggle to negotiate these kinds of things.
I think that there's also, may I interrupt for a minute?
Sure.
I think there can also be the belief, because if the therapist holds the belief that you're able to work through this pain, you're able to work through this condition or this situation, they may have little understanding that these structures are always in place and they're always impinging on what this individual is attempting to do in terms of survival, as well as finding some psychological health. And so in some ways, although the therapist may feel that they're doing the right thing And the best thing, they've lost their client because they haven't matched where this client is coming from in terms of that worldview is such that political, social, and economic structures are in place. They're not going to change anytime soon, in as much as we might want them to change. So they're out there. But if your therapist continues to feel that if you work hard enough, you can work through this and you can get better, you can have a better opportunity, then they are losing sight of those political, economical, or economic and social structures that exist.
And I think there are other factors that often may be seen as disrupting these coalitions, that often people of color are often sensitive to the potential for having what for them is the painful history of a struggle with racism compared to or appropriated by white Americans who they see as having other identities that are marginalized when it's convenient for them to claim that marginalization and allyship, but that they experience a kind of disappointing dissolution of those coalitions when their white counterparts who, even if they have invisible marginalized identities, have often less experience managing the stigma associated with those identities and find them dangerous or inconvenient to claim. Or when they're rewarded by dominant groups for their silence about racism within and outside of their ranks. And so there is also sometimes a certain level of suspicion about when people choose to be supportive and then when they're MIA, and whether or not to trust entreaties of support or potential support. There's also, I think it's important to understand the marginalization within marginalized groups and the way it can position people to feel that they have no place of safety or they have no place where they can bring their whole authentic selves, that there is always some piece that's not welcome, and the ways that that can complicate therapies in terms of helping people develop a sense of connection and belonging.
You know, I'm realizing we've been speaking for almost an hour, and I'm just curious to use that word, which is very important in therapy. Just, you know, for those of you listening to us, you know, what or why are some of the reasons you've either experienced yourself or you've seen other of your peers struggle with that keeps therapists from being able to join with, for me, or validate clients' sharing of their grief and pain, for example, with racism or homophobia, transphobia, sexism? What are some of the reasons you've seen that people really just struggle to own privilege? And you can just put it in the chat if you like.
Or disown it.
Or well, yes. Perfection, thank you. Somebody has said, I'm not going to say names, but perfectionism, needing to appear as a good ally. Excellent. That's absolutely true. We want to be the best. We want to be right. And one of the things that I've become aware of myself in terms of my own socialization as a professor is, you know, and I train people, right, is we're usually socialized to be right. So to acknowledge that you're off, you're wrong, you don't know something, you don't understand something is something that we may fail therapists in our training because we want to be right, we want or need to appear perfect. And then the other one was need to appear as a good ally. So it's not even about, it's about almost pretending to look good, right? It's the whole, the way of how we appear to somebody rather than how we actually are. I think that's one of the more common comments I've heard from white colleagues and other colleagues, right? I don't want to appear racist. I don't want to appear offensive. The fact is the more scary thing is I don't want to be offensive. I don't want to be racist, etc. Thank you so much. And then there's another response. There's shame related to privilege. So that's absolutely profound. Something that you can't get rid of, just have. And it makes you undesirable in some sense, especially when it comes to race. So if I join, I have to admit some things about the current structures that I benefit from. That's beautifully said. And so true, right? If we acknowledge and own privilege, we have to own that we didn't do it all by ourselves. We're here because somebody else didn't get, or a lot of other people didn't get the same chance that I did or you did. Thank you so much for those responses.
And the culture of rugged individualism makes it hard to do that.
Right.
Because that the myth of the meritocracy is supported by the assumption that people just get what they deserve. And if you get misery and inequity, you deserve that somehow, just as much as if someone gets wealth and success, well, they must have deserved it.
Yes, yes. And a third attendee has said, sharing an experience of marginalization while also being privileged would feel like it's just not enough marginalization to even voice, or certainly to throw a sense of, yes, I understand what you're struggling with. And I think that is a very common struggle that therapists can have, which is feeling like from your pain, you can understand someone else's pain. So, Bev, Angela, any of the audience, what might be a way to think differently about that fear, which I think is a fairly common fear?
Well, I can make a suggestion. I'm a light-skinned African-American, and colorism makes having light skin a privilege. And it doesn't matter that I didn't ask for it, but I accrue the benefits that are a function of it. However, I don't feel like I'm guilty of something because I have it. What I have, if you have privilege, the question is, how can you use that to help people who don't? Not that, if you don't have it, so somebody's going to have it for a long time to come. But if you have it, are you aware of ways that you may be abusing it? Because, I think what some of the people who raise questions are indirectly alluding to is when you feel guilty about something. As a therapist, if you're motivated by your own sense of guilt, you're not responding to the patient. You're responding to the need to remove yourself from the discomfort of feeling guilty about something. But it's important to ask, what are you guilty of? What did you do? Rather than this sort of existential notion of, oh, I have this. Well, that may be true, but now what? What does that mean? Having it doesn't preclude understanding what it's like for people who don't have it.
I think the other thought that I had was we have a relatively dichotomous worldview from a Western perspective. It's either this or it's that. And when we're talking about intersectionality and when we're talking about intersections of identities, in some respects, some aspect of an individual's identity does come with privilege at times. And they are negotiating the very thing that you're talking about in some ways. Although we are certainly saying that these are minoritized identities, there are several others that we haven't talked about. Ableism, education, those all are a part of what can continue to privilege an individual, yet still feel the experiences of discrimination and oppression. And those are not necessarily mutually exclusive. You can have all of those. And I think that's why we're calling this a very complex process, a complex understanding of how do we negotiate those positions and those places in our environments. Our world likes, especially Western world, but probably many other places, it likes to divide us in nice, neat groups. And it overtly privileges some groups and does not privilege others, but people are all in the margins, or they're all intersected in many of those groups. And so if we talk about it as a numbers games, you have more than I do. I have only one kind of discrimination. You have three. A lived experience of discrimination doesn't add it up that way. A lived experience of discrimination understands it and feels it. And then you have to negotiate that. And I think that's the core of what we're trying to convey here, is that trying to understand that kind of complexity and having that kind of conversation in the room with your client, allowing them to talk about that complexity, that is significant. But by ignoring other identities, by only highlighting one, or maybe that individual is really only aware in many ways consciously of one form of discrimination and only talks about that. Well, that's what they're aware of, but they are being impacted by other forms as well, but maybe just can't articulate that yet. And so our job is to know that discrimination and oppression is difficult, is painful. And whether it's 1, 3, or 5, understanding how it's impacting that individual in their life, in their relationships, in their job choices, in what they see as their accessibility, that's part of the work of what we're here to do.
And
What you're addressing that I think is really critical to the work is the importance of narrative. And, we live in a world that's become even more reductionistic around mechanistic kinds of therapies. And, I think having empirical science as one of the underpinnings of our work is important, but I'm not moved by data points or a graph. I'm moved when I hear someone's story and I have a sense of what their experience of the world is like. And I think the important part of the work of the therapist is hearing that patient's narrative. What is the world like for them? What do they have to do to get through the day that has a psychological cost attached to it? I mean, we all have those things, but what is it for that person? How do they understand it? What do they make of it? What does it feel like for them? And to also be prepared for the likelihood that when you start digging around those things, what comes up is not going to be pretty. And, it sort of gets back to the notion of the therapist being able to hold that person's grief and pain and intense emotion in those situations without being afraid of it and needing to run away from it, as sometimes happens with patients of color when they're expressing feelings intensely. The stereotype fear is somehow when people of color express intense emotion, something's going to get out of control. And if something's out of control, they're going to hurt someone because there's a pre-existing perception of us as always the prospect of dangerousness lurking under the surface. And I think therapists who are feeling insecure about what they're doing are more vulnerable to sort of feeling like, well, let's just calm things down. That is less likely to be helpful to individuals in those situations where they need to be heard.
I think what you just said, Bev, really touches on what a comment was in the chat, where the therapist may get passive rather than trying to meet the realness, is what the person in the chat said, but the reality of what is occurring for that individual. And I think it's very easy for therapists to be passive. They are in the room, but they're not engaged in a way where they can truly hear that pain and that context that the client is talking about. And because they're being passive and because they're not engaged, they're not really doing therapy. They're sitting with that individual, allowing them to talk, but they don't have the mechanisms, the conceptual framework to now, how do I move forward in what I talk about? What questions I ask next? And because I don't know, I sit passively, which might be what that first person said, Marie, right? When that person said perfectionism.
Perfectionism.
Go ahead.
Yeah, so I think exactly the perfectionism, and as another person later said, how inauthentic we can be. What does whiteness mean? What does privilege mean? I think this is another area of failure of psychology, and including our training, is we do so little work, not just on oppression and discrimination, but on privilege and its benefits. And so the complexity that adds to that person and passively listening in the room, to what extent is that a way of protecting their privilege in that moment? And so I think it, before people start seeing clients, or even as they're seeing clients and they're working in supervision or with a peer group that's their consultants, I think we just need more discussion, more owning of our own feelings regarding privilege status and our sense of feeling threatened or anxious, or all of those feelings when we allow somebody to express pain and grief and we sit silently, or with our hands tied, or with I don't know what to say, those kinds of things. That's moments of privilege that get in the way of just a basic clinical skill. If somebody were crying about the loss of something or someone important, that's not necessarily a privilege thing. So we lose our ability. It sort of suffocates the clinical skill to just simply provide emotional validation for a painful reality. And as we've been saying, these are realities that aren't going away. And it just, I think one of the things that Bev said in the earlier conversation is you can't behave yourself out of this circumstance, right? It's not about being a better student or a better citizen or any of that, in the sense of responding to crazy laws and harmful policies out of rational, I need to change something myself. It's not about the self to change, other than acknowledging those structures and then working in concert with others to change those structures.
True. And I'd like to just dovetail on one other thing in terms of what you were talking about with privilege. We certainly do. We talk a lot. If we talk about this in our training programs, we'll talk about oppression and discrimination, but we don't talk about privilege. You're right. And I guess I just want to just say something about that experience of shame. When the person in the chat talked about the shame that's connected to the privilege, one part of shame is that it closes you off. It closes you off to not just understanding yourself and what that shame is about, but it doesn't allow you to connect to the shame of your clients and what that means. I'm not saying that your client is feeling shame, but at some point your clients feel shame about something. One of your clients has that experience. And for you, the person who's talking about that, it could really be important, or any other person who's feeling that way. It could be important to see or ask yourself, when this feeling of shame arises in me, what is it that I do?
Mhm.
Or what is it that I don't do? How does that affect what I'm doing in my work? So shame is a deep-rooted feeling and goes back to a variety of things.
And one we usually want to get rid of.
Rid
as
of.
quickly as-
We want to get rid of it, correct. But in getting rid of it or hiding from it or being passive with it, we end up not examining it
Mhm.
and not asking ourselves, what am I doing in my own reaction to it? How do I shut down others in my own feelings of shame? So I do appreciate that person said that in relationship to this, but it can't stop with just that.
And
And
I would expand what you're saying beyond shame. That it seems we've moved away from the idea that whatever feelings you're having with a patient, it's important to understand something about where that's coming from, what that means for you. Why are you feeling that at the time? And I think sometimes to give our students language for exploring many of these things, that it's one thing to say, well, go explore whatever. Often what my students say to me is, well, I don't know what to say. What is the question that I should ask? And that's, you know, the gist of which is probably not just with this population, but for most patients, life is both and. It's rarely either or. And I'm thinking in terms of something we really don't talk about a great deal in training around temperament and personality. One of the things we have to be able to tolerate and embrace is ambiguity. That sometimes the answer is just not clear. And there has to be a certain kind of comfort sitting with, it's just not clear. And it's not because I'm not asking enough or the person doesn't know how to communicate. It's the nature of what some things are, is that they are ambiguous until they're not. The other is anxiety. And what one of my colleagues often says, she tells students, if you want to be a therapist, shake hands with anxiety, because you're going to be either managing yours or somebody else's throughout your professional life. That's what we do. That's a part. It's not some aberrant, monstrous thing in the room. It's part of life, that things make us anxious, things make us have feelings. And the question is, what are those feelings about? Where's that coming from? And also how much of it is intersubjective and not just either it's coming from me or it's coming from you. What are we co-creating in the room? And I think of it also as temperament around, when you see someone suffering, what do? What does that evoke? Do you seek to comfort, or do you need to get away from that? Or do you need to fix it? Those things all can have very different outcomes, but it's important for therapists to understand what it is and what it means for each of them. I sort of thought about questions that can be asked when you're trying to understand the nature of a person's racial identity, or moreover, their history of experiences. And it can involve asking people what they prefer to be called, how they arrived at that. because it's more than a checklist. It's the question, but it's also now, what does that mean? I was asking questions about, what's the earliest you can remember being aware of who you are racially, as well as in terms of sexual orientation. What did that mean? Because I know that young children of color can identify the nature of, well, they're this, but that doesn't have any meaning necessarily. And so when did it start to mean something? That it meant, oh, you're part of this group. Well, what does it mean to be part of this group and not part of that group? What did that make you? What were the messages that you got about what that means? And who gave you those messages? Where did you get that?
Exactly. Yep.
What was perhaps your earliest experience of something you would label as racism? What did that feel like? What did it consist of? What did you do? Where did you get the idea that that was the thing to do in response? If someone talked to a parent about it or a family member, how did they respond to you? All of those kinds of things give you a much more in-depth picture of someone's experience. What was the worst experience you had with racism? What was the most recent? And of course, one can do that with other forms of marginalization and other forms of identity as well. But I suggest them around race because often people can have experiences and then just kind of stuff them someplace. And they don't necessarily think about how that may have shaped where they are in the present. That often we are not spending enough time on history. And the history of a person is complicated and time consuming to really explore. But there's often such a rush, to get the form filled out. And the other things that administratively people are often under a lot of pressure to do that we miss. There's a reason that we're taking that history. For many patients, when you begin asking those kinds of questions, even sometimes when they don't have a response in the moment, it stimulates thinking about it and it comes up. It can come up the following week or it can come up later on when something evokes it. But you're modeling something about helping people have this way of self-exploration and self-inquiry.
I think these,
and that you're listening.
And the other thing I was going to say is these questions also are part of a liberation process. When we think about liberatory psychotherapy, you're helping people reclaim their history, their personal history, as well as their collective history, to help them develop their own narrative rather than one that was taught to them either by negative stories or actually invisibility of stories, because that's been still a common occurrence in many school systems. So those questions are also not just revealing to the therapist, there also can be a form of healing and the beginning of the process of healing, because you're helping clients understand their story from their perspective. And you're helping them reclaim a sense of connection with other people who share this experience. And that's absolutely key to healing and to moving beyond feeling stuck, or the reasons many of our clients come to therapy, that they feel anxious or angry or somehow unmotivated, et cetera, helping them unmask the oppressive circumstances, even by these questions that seem simple. They're not. The answers begin us down the road of that complex narrative that we've been talking about, of the intersections of, you ask about race, ask about gender, ask about sexual orientation, class, there are, really basic foundational group experiences, that our origin stories are often denied, masked, distorted, etc. And so therapy, with somebody who's competent in this way, can help unleash, unlock, and even to help move people forward to seeing that these circumstances are ones that must be changed in some important way for themselves as individuals, but also larger, more societally as well. That it's not the person who's sick, it's the structures that are.
People are trying to manage social pathology.
Yes.
And if they fail to do it, then they are pathologized.
That's right.
It's their fault.
Well, I was also thinking that the narrative and someone validating that narrative is, like you said, Marie. I mean, you certainly described what gaslighting is in a much more eloquent way, so that people understand that what people have learned in some ways, or maybe what they have internalized, is a distortion often made by other people's responses to you. So it gives you a distorted idea of your reality, such that sometimes you lose touch with your reality. And that puts you in a place of anxiety, of course. It puts you in a place of not being able to effectively communicate with others, such that if you wanted to be authentic, it's harder to be authentic. So yeah, those were the kinds of things I was thinking about as well. And I think that hearing from a client the messages you heard helps them articulate things that, one, they may have forgotten. It may have just been dismissed a long time ago because someone else told them that's not really important.
That's right.
You don't really need to think about that anymore. Or are you upset? Don't worry about it. Don't be so upset about that. Or you're too sensitive. Those kinds of remarks distort people's experiences of reality.
And they may come from loved and trusted figures.
Absolutely. Oftentimes they do. Oftentimes they do. And for those people who are making those statements, I don't think it's always malicious. I think for some, it could be a parent who says, I just don't want you to feel bad, baby. I don't want you to feel bad. And, it comes from those spaces and places where then the client is left saying, how can I be mad at my mother? She was only trying to protect me. But in as much as that may have been the intent, the outcome is not that.
Well, because it could well be from that mother's inability to, one of the things about that can be helpful about asking those historical questions, and I think in general in therapy with patients, how did you come to know what you know about you and about the world? Where'd you get that information? And sometimes, well, you could love that person, but that doesn't necessarily mean that information was reliable, because it's about helping people understand that the people they're connected to have their own stuff. That the mother who says, I didn't want you to feel bad, is feeling like she is inadequate as a mother if her child is feeling bad, and she doesn't know how to address that. And so the messages just don't feel that way. So I don't feel inadequate about not being able to help you with this. But people don't necessarily see that aspect of the person, and that the person that they're getting information from is struggling too.
And the other thing is, it also helps illuminate how and why we have complex feelings toward that same person, right? So a mother may really get certain things about maybe race or even gender, depending on generation, but LGBT issues may not. And so may be able to be affirming and visibilizing in a way, of somebody's experience for one thing, But when it comes to another intersection or aspect of identity, no, not at all, is not able to be there for that person, even though they know that they're trying their best, but that may not be the person who's going to give you that affirming presence. And so how and why this gets complex very fast is when we move into multiple of identities, as we're talking about with LGBT folks of color, is these are multiple complex identities and experiences that are happening all at once, especially once adolescence occurs.
Mhm. One of the things that comes up sometimes for kids of color in this, and that we've talked in this group before about racial socialization, and behind the neatness of that expression, the terror within which many parents of color live. Where I just had a webinar this afternoon with some folks in which one of the mothers said, I feel like I'm always living in anticipatory mourning for my son, that he's going to get killed, that the nature of the world is such that he is walking around with a target on his back. And if you imagine many parents sort of living with that sense of they feel like they're just trying to save their kid's life, and their homophobia, while some of that may be homophobic, there also may be an aspect of that that is just fear. That is, this is going to make you more vulnerable. This is going to put you more in the crosshairs. How can I support something like that? You know, aren't you at risk enough? And the way those things collide, superficially can just seem unsupportive, but there are a lot of other things going on underneath, that it might be helpful for a patient to understand. That I'm thinking of the work of Kathy White, and who is a psychoanalyst here in the city, and she says, these things are all kind of collections of projections. If you think about the core of racism and white supremacy ideology, gender misogyny, homophobia, these things that are projected onto people, these negative attributions, are feared parts of the self of the people who are engaging in the projections. And they are not necessarily reachable by facts or logic, because delusions don't get dismantled by facts or logic when they serve a defensive purpose. But I think sometimes when people are struggling, they don't always see how the people they're taking their cues from are flawed. That there is, it gets back to the notion of, where do you get the information that you get about who you are and who somebody else is, and who are they really? Is that necessarily accurate? It's part of the notion of developing a skeptical intelligence, that you don't have to believe something just because somebody said it and they're an authority figure or they look like they know what they're doing. That you can think about those things and explore them independently, and giving people a sort of sense of mental freedom to do that. That, again, as your point about people feeling stuck. Well, what if we don't look at it as it has to be that, but maybe it could be some other things. And maybe you have it right. Maybe it's not, this other sort of construct about who you are or who other people are, or what you have to do, or what you have license to do or don't have license to do. that more addresses the area of freeing patients up.
Freeing them up as well as empowering them.
Yeah, that you don't have to just take what you're given.
That's right.
Yeah.
And I think that probably is something that communities who have experienced a great deal of oppression and discrimination are struggling so much with the experience of that it can be difficult to then emerge on another way of challenging what is occurring, what's making it occur that way, and do I need to be a part of that in ways that I've been a part of it in the past. So because you may be a victim, as we might call that, and I'm using that word very loosely, it doesn't automatically put you in a space that you have to continue in the thinking of that you have no choices. Because that can keep us just as stuck as anything else.
Yeah, I mean, I think that's the true liberation there, is helping people see there are choices, even though they can't choose certain identities or certain structures in which they live. You know, that's one area of therapy. The other one is, now that we know these things, now what? What choices can be made within this context?
So the choices that could be made in that context, and also the choices about how you've been thinking about yourself, how you've been thinking about what you've been doing in this space and in this situation. You know, I was kind of struck when you said, Bev, do we have to believe those in authority? Do we have to accept what they're saying as true? And, you know, most of us in school have been taught to do that. It's one of the very first, you know, in kindergarten.
All children are taught this.
That's
exactly.
Right. What did the teacher say? This is what the teacher said. What did my parents say? This is what they said. And we don't encourage, or certainly many groups don't encourage, not so much, is it true or not, but can we talk about that? I might have a different idea about that, which is different than disobeying. Because I know that there are some cultural groups where when children speak up, it's automatically seen as disobeying.
Well, and that there are ways you can question things in your head. If you can't question the person who is oppressing you with whatever that idea or ideology is, that the reality is none of us believes everything we're told. And it's sort of, it's often enlightening to help patients sort of think about, well, why did you believe this and not that? You know, what was it about this person or this idea that made this believable and something else not believable? But sort of, how do we come to know what we know? And being able to ask that question of the self. Both therapists have to ask that question, because a lot of what we know as a function of training is a lot of nonsense. But also to help patients kind of have, Marie, you use the term curious, have this curiosity about themselves and about the world that says, well, maybe it's that, but maybe it's not. And, you know, sort of, where are the facts?
The other good question would be, when did you stop believing what you were told about X, Y, or Z? And what happened next? What did you do when you stopped believing that? And so again, I think it brings to light the ways in which people have made choices, the ways in which people have either felt that they had to conform or not. And because of those feelings of conformity, let's just say, how did that cut you off, marginalize you from yourself?
As anybody out there want to say something or have?
That's questions at this point, yeah.
Hi, this is Marlene. I just want to make a comment. Thank you so much. This is very rich and inviting of examination, especially self. When you talked about the perfectionism or the shame that causes therapists to become passive, to check out, not be present, that experience is also happening in the training programs, where when you bring up the issue of privilege, you have some trainees who either attack, especially if they are faculty of color, or you have trainees who say, I just can't go there. I can't do that. And so we're already a field, mental health, where we have not really talked about these issues, as in particular privilege, enough, and identities as well, and especially race. And so we have a lot of people who are teaching, training, who themselves become passive or check out or placate, and some for I want that promotion. And we count on evaluations. That's a part of my portfolio, my teaching evaluation. And so I just wanted to raise that point too, that we're really dealing with some critical issues around training. I wanted to just re-emphasize that.
Well, and I thank you for that. And I think sometimes we have to consider the kinds of decisions that we make about who we train. Not everybody can do this work. And it's, while you can teach people the academics, you can't necessarily teach them capacity for empathy, self-reflection, and I guess lack of self-absorption. And I don't know that there obviously is not a perfect way of parsing that out. But I think when we're interviewing people, we have to think about asking the kinds of questions that require some capacity for self-reflection and don't have canned responses. And often we're overwhelmed when we're engaged in that process. And there are a lot of people to see and a lot of decisions to make, and we want to make them quickly. And it doesn't always serve us to do that. The other is that I think it means going back to understanding how our disciplines have been dominant cultural tools of oppression and subordination for a very long time. And it sometimes amazes me that I'm still having the same kinds of discussions with some groups around, okay, why should you talk about race in therapy? And I'm thinking, I was talking about this 30 years ago. Are we still doing this? Is there still a question about why you would need to talk about race if you're working with a client of color? Apparently there is, but the use of institutions to reinforce the dominant cultural status quo is part of what a certain amount of training becomes. Training is a form of indoctrination. And, people pick and choose when they're trained about what it is that sounds reasonable that they're going to accept and what they're going to kick to the curb. But within that process, I would think it needs to be made clear that these are things that one is going to have to be able to demonstrate they can do in the course of training. That's just part of the deal. And it's sort of like, if you can't stand the sight of blood, you probably wouldn't do well being a surgeon. Not because you're not smart enough, but that's just part of what you're going to have to encounter all the time. And because part of our role is that of gatekeepers. Somebody who says, I just can't go there. Well, what if that's where your patient is? And you can't go there? How helpful are you to that person? Our initial ethical mandate is to do no harm. Well, what are you doing if you can't go to places with the patient because you don't want to go there yourself? What is that about?
The other, in addition to Bev's really thoughtful response, the other thing I heard in your question, Marlene, is professors and trainers themselves are in this context and also may feel vulnerable to some of the same oppressive forces that the clients and even our students are in. And so I appreciate that challenge. And I'm sure all of us on this call at different times have made choices, right? But the choice to fight the right battle at a certain time, and just staying with that, right? That's part of our moral imperative of ensuring that we are doing what we need to do as trainers and as faculty members, and of finding a supportive community in that system, speaking with the supervisor about the need and the importance of raising these issues, being involved in a faculty retreat where this comes out. And hopefully you're not an only person in that faculty. I started my career as being an only 25-ish years ago. And yeah, those were really challenging conversations to have about bringing in race and culture as part of the training, bringing in people of color as students in the program. So I would imagine you and other trainers on this call or listening to this recording, yeah, I mean, there are times where maybe we're not going to put ourselves in that risk, but there are times where we feel we must. And I know, we're here for that reason, that we just make those choices. And the more we push ourselves as professors and as trainers to take some of those risks, or to think about asking in a way that, we may never get away with that defensive reaction, but in a group of 8 or 10 people, there may be somebody else responding to that defensive reaction saying, what's wrong? What's that about you? So there are various ways of dealing with that. But I also wanted to affirm that sense of vulnerability that trainers and faculty, particularly those who come from marginalized experiences, may feel as well. And that may be part of this process too. We've had 50, 60 years of multicultural psychology now in the United States. And yes, it's a push-pull, but I appreciate that we've been invited to have this conversation, because to me, that's still a hopeful sign that at least folks at the Ackerman Institute care about these issues and really want their students and their staff to kind of understand and to be in this moment with us.
Absolutely.
And it's another way of doing it, by the way.
Yes.
Usually when I'm asked to come and speak, I ask the inviter, okay, what would you like me to talk about that you can't say?
Exactly. I think using those other ways of teaching, other modalities of teaching, bringing in podcasts, bringing in a variety of other ways of introducing this material to class members can take the vulnerability away directly from the instructor. There could also be the readings that we are now, that our literature has many more readings now than when I was in graduate school. And making sure that those are incorporated in the class readings and materials, and actually getting our accreditation boards on board,
Yes.
looking at syllabi and ensuring that syllabi contain this kind of material in each of these courses.
You're absolutely correct. It's also important that as trainers and faculty, we understand that talking about it is not doing the work. And we need to be clear about doing that work ourselves too, so that we can ourselves go there.
Exactly true.
Mhm.
Very good. Yeah.
You know, I think we might want to say something about the nature of the times we live in, and what's going on around as we're talking about the need to give voice to more voice to this material. We have people running around the country talking about taking books out of libraries and forbidding certain kinds of conversations in schools, having, and by the way, the Brooklyn Public Library has extended free electronic membership to, I think if you're over the age of 13, any kids around the country who want a library card so that they can electronically borrow books that their local libraries have banned. So there are things going on that are working to the good, but we're living in this bubble where there is a concentrated attempt to re-whitewash history and to remove any of that information that was considered not the dominant cultural narrative, to basically reinstate that that material. Nicole Hannah-Jones gave a webinar recently on her work on the 1619 Project, which has gotten just some excoriating responses. And I asked her, well, did you expect any of this? And she said, well, when you write stuff, you expect that you're going to get some negative or critical response to it. That's not unusual. But she said, I never expected the powerful blowback on this. And she said, all it is another narrative. It's not the dominant cultural narrative. It's another narrative about what the beginning of this country was, because in fact, there were slaves here in 1619, and that was well before 1776. And our first 5 or 6 presidents had slaves. And so we're back in this place where we're not supposed to talk about those things. And that's going to make it somewhat more challenging. But we have electronic media. So people who try to restrict people's access to this material are going to find it somewhat harder to do that.
We had someone who had a raised hand. Does that person wish to ask a question or provide a comment?
Yeah, that was me. So I just wanted to say something was said about not wanting to put oneself in a position of being the first. And this is directed to Dr. Greene. So I was a grad student at St. John's when Dr. Greene got there. And I was a white woman from Westchester County. If you know New York, and I had been in Harlem working there. And to have Dr. Greene, Dr. Greene, do you think you were the first?
I was told that I was the first tenure track faculty member in the college.
Right. So, to those people, either we counsel or we mentor at this point. I'm 56, so there's mentoring going on, or we see those people who are the first are so important to those of us who come after.
Mhm.
And even if we don't look like you are still that important to us. So I think all the work that people who are the firsts do, it's amazingly important to the rest of us. So just wanted to say that.
Well, thank you for that. And, somebody's got to be the first. I think people
Like it or not.
who are the first and only have to consider the nature of the hostility of the institution that they're in, if they're going to do that. Because we don't want people to kill themselves because they're the first. And it can be an awfully isolating, punitive place to be. But there are also communities of support that one can find. And people can come to be the first in those situations from different places. I was at an advanced stage in my career, and academia had been the anti-plan up until that point. So it wasn't my career vision. I saw myself as a clinician and really enjoyed the work that I did in hospitals and places delivering clinical services. So I wasn't stuck on, I got to be an academic or there's nothing else. So that's a different kind of perspective. And I was older. I wasn't just getting out of graduate school, hungry, looking for a job. So, and I didn't sanitize my CV. I was a founding co-editor of a 5-volume series of books for the lesbian and gay psychology division of APA. And when I took that position, I thought, I am not at this stage of my life, which was near 40, gonna leave one place that I was in that I thought was oppressive to go to a different kind of oppressive. If they need to see that this is what it is. And in those days, if you wrote about anything LGBTQ, people assumed you were. And it sort of felt, and that has to be okay. And if it's not okay, here is all this stuff on paper. And to their credit, they still wanted me to come. And I thought that was significant. So, I think when we mentor people, you have to consider where somebody is coming from, what stage of their career they're in, what's the nature of, I was the first, but the institution wasn't, well, my department wasn't hostile to what I had to bring. And sometimes you have to make a distinction between what's the life in the department as opposed to the institution.
And I think that's what helps the training of the trainees.
Mm-hmm.
We talked about the training, and that's what helps our training is, seeing everything and experience everything and different points of views, not just one. So that helps the training.
And the department was on board with that, even though the institution was still playing catch up.
Correct.
And there were some other people in the institution who strategically wanted to see those things happen.
I'd also like to just say too that you don't have to look like the person that is the other, which is what I think part of your point was too.
Exactly.
To know that you are making a difference for others, and that kind of mentoring, that's the unseen mentoring that goes on. But it is good to know that it is still felt and is important.
Very true.
The person who was probably most responsible for my becoming a scholar was an elder Jewish woman who was the chief psychologist in child and adolescent psychology at Kings County Hospital. She was as far from academia as you could get, but she was that person who insisted on using her authority to force me to teach courses on working with minority clients, none of which I wanted to do, mind you. This was extra work. And of course I thought, what are you kidding me? Teaching courses and training programs with physicians who have little use for psychologists anyway, and even less for someone who is a Black woman who was a lesbian. And I just thought, you got to be kidding. But she invoked her authority, insisted that I do those things. And most of my early publications came out of that activity that I had no intent on pursuing prior to that. So who your mentors are don't have to look like you.
Any final comments or thoughts from the panelists?
Well, thank you for this invitation. I hope it was helpful.
It is incredibly helpful. And I am so delighted that all of you could join us. And I think it's going to be an amazing book. I can't wait to get a copy of it when it's out.
Neither can we.
I know how that goes.
Unfortunately, we have to write it first. So
Yeah.
and then onto the page.
Yes, yes. But this has been really, truly an amazing presentation. You covered quite a lot, and I hope that many people will see the recording because you had such great things to impart, and also practical things that people can do and can consider that can help them to become the therapists that they really would like to be, that they hope to be, but that some of these things we talked about, perfectionism or shame, may get in the way. So I want to personally offer my gratitude to each of you, and again to say that we are so fortunate to have had you to come and present this to us in our social climate. And I love that you talked about social oppression. It is so important for us to think about these issues, and for clinicians to think about what's happening and how we may experience more social oppression as a result of some of the policies that are coming down, some of the state laws that we may have to contend with. So thank you very much. And to the audience, thank you so much for your participation tonight. Again, thank you, Melissa and Sierra, for your support tonight, and to Jamie for her support earlier. So thanks,
Thank you.
everybody.
Thank
And good
you.
night.
Thank you too, and thank you all for coming.